Hello, I'd like to talk about how work with patients who've suffered a hip fracture has advanced our understanding, and in particular my understanding, of the conditions of dementia and more recently delirium. I think anybody who's worked on an orthopaedic ward, or indeed on any general surgical ward, or indeed in any hospital ward looking after frail and older patients, will be familiar with the scenario of somebody who's old, who's admitted with an acute event, in this case a hip fracture, who may have successful care for their original problem, but becomes bewildered after a while in hospital. And this state of confusion, the development of acute confusion, is something that I want to try and tease out. Most of us would recognise that this patient may be suffering from dementia, and that perhaps hadn't been picked up when she was admitted to hospital. But how that relates to the development of this more acute event is worth teasing out. To start with, what do we mean when we talk about somebody as having dementia? I'm not going to talk at length about dementia, but I think it's worth trying to disentangle the patient who has dementia from the patient who has delirium. What do I mean by somebody who has dementia? I'm thinking of somebody who has a progressive, irreversible damage to their brain as a result of degenerative change, vascular disease, which leads to progressive loss of not only memory, though memory is the aspect that we talk about most frequently, but all aspects of their cognition. How we make that diagnosis is relatively simple. There is an expectation among staff on wards and families that you make the diagnosis using a brain scan, or that you might need to do blood tests. But actually, that's not really how the diagnosis is made. The purpose of scan and blood tests is to identify other things that might be masquerading as dementia. You make the diagnosis of dementia by listening to the family. And this single question in dementia is a very useful way of encapsulating what's going on. So you're looking for evidence of memory difficulties over the course of a number of months, so many months, years sometimes, to the extent that it's significantly affecting the patient's daily existence. People are very much more comfortable talking about memory difficulties. We're all more familiar with them, and the general public are more familiar with them than the ability to identify that the patient may have lost their powers of concentration, that there may be subtleties of personality change, and so on, all the other things that happen with dementia. So as a single opening question, this is very effective as a way of identifying somebody who has a problem. But you're looking at a prolonged period of change, in particular in memory, that's having an impact on the patient's life to make the diagnosis. So that's the history, and we follow history with examination. And for many years, mental state examinations of various types have been bandied around as investigations to use during people's time in hospital. And we've been doing the abbreviated mental test score for pretty much everybody who's admitted to hospitals in England, Wales and Northern Ireland for the last decade or more. Everybody's having an abbreviated mental test score, and that gives you a sense of not only memory difficulties but some of the other aspects of cognitive change. You could do the same using a whole variety of other tests, clock face drawing, MOCA scores, mini mental state examinations. Some of those very quite hard work to do and challenging to do, and in acute setting of relatively little use, in that, as we're going to come on to see, the effects of dementia can be hugely overridden by the consequences of delirium, which those tools are not really geared to dealing with. They're much more suited to the GP, that's the memory clinics, outpatient management of somebody who's in a stable situation. But between the family history of cognitive decline, an assessment to demonstrate difficulties in cognition, and the exclusion of other diseases on blood tests and scans, it's relatively straightforward to make and intervene in respect of dementia. So what do we mean when we talk about delirium as an alternative or as a complication of dementia? What we mean by delirium is that the patient's brain, their cognitive abilities, their thought processes, everything becomes overwhelmed and bewildered by a concatenation of circumstances during their time in our care. So the lady who I talked about at the beginning became delirious for a whole variety of reasons, and we'll come on and think about those. But this is a reversible condition, unlike dementia. This can be expected and should be anticipated to be reversible because we need to make every possible attempt to reverse it. It's not that the brain has structurally or physically changed, it's that it's not coping with the complex circumstances in which it's trying to function. How do we diagnose delirium? Well, again, let's go back to a simple history and examination approach. The question in terms of delirium, the single question in delirium is very simple. Do you think they've become more confused lately? So there's this emphasis on confusion as opposed to memory. In lay terms, talking about confusion becomes much more meaningful. And lately, we're talking about problems that have arisen in the course of days and weeks, hours, not something that's been going on over the course of months, which is more likely to reflect dementia or some sort of space-occupying lesion or cerebrovascular disease, that sort of thing. Examination. Well, the examination for delirium, there are a variety of ways of approaching it out there, and I would very much recommend that you look at the 4AT score, the 4A test, as a screening tool for delirium. This is a test I do 2 or 3 times every day of my working life on patients in the perioperative period. I've learned more about my understanding of patients' confused state and patients' thinking apparatus, their ability to rehabilitate after hip fracture has been advanced far more by this single test than by any other test in neurological assessment. In fact, it's rather depressing to find that neurological examination still seems to focus on being able to map dermatomes rather than being able to assess patients' cognition using this test. How does it work? Well, it starts with the AMT score that I talked about earlier. These 10 questions that test somebody's overall cognition, and it throws away 6 of them. So you get to a very simple 4-item abbreviated mental test score. You're asking patient's age, which year they were born, what year it is now. So it's quite easy to triangulate between those and work out whether they're answering correctly and ask whether they know where they are. But that test, which is very effective and is highly predictive of the result of the 10-item AMT score, isn't of itself sufficient to diagnose delirium, because delirium masquerades in a whole variety of different ways. One of the things that you need to look for is that somebody has changed, and just being sensitive to the fact that though this person was performing slightly poorly when they came to hospital, they're now performing very abnormally. The fact that they were very abnormal last night, even though they seem okay on the ward round in the morning. Listening for anybody telling you, family, carers, staff on the ward, telling you about changes in somebody's performance. That's hugely important. The third thing that you need to check for is whether the patient is alert. A definition of alertness, this approach, is something that's useful. It's very easy to go do your ward round in the morning. The patient seems to be quietly asleep. It seems cruel to wake them because they've had a rousy, a difficult night. It seems unnecessary to wake them. But actually, if somebody is drowsy, this may be what we call an apathetic delirium. The person is delirious and unable to wake up. So testing for that will identify a group of patients who, if everybody walks past their bed each day, they won't get food, they won't get rehabilitation, they won't progress, and nobody will identify the underlying causes for their delirium, so they won't get better. So it's a really important group to be picked up, and the 4AT score will do that, whereas an AMT score might not be so sensitive to it. And then the third additional aspect of the 4A test is examining patients' attention. This is the approach taken in the 4A test. You could do the same with the days of the week in reverse order. But what you're trying to do is to get the patient to concentrate on a task and to remain concentrated, paying attention to that task. And it's very easy when to think that people are going to be able to function. But when you do this with them, you find their attention's wandering, they're not able to focus on what you're doing. They're not therefore able to focus on what you're saying to them when you're explaining what's going on, when you're telling them about their operation. They're not able to focus on the nurse's questions, and they're not able to engage with and benefit from physiotherapy and so on. So patients with attention difficulties, which are a powerful marker of delirium, have a very poor outlook unless the underlying causes are addressed. So using 4AT assessment, we would identify that this lady, there's a change, she seems confused. We would identify that she has delirium. I do this test so many times on people who I don't think have delirium and identify problems that I would have missed in conversation, despite having had the same conversation with thousands of patients. So do go and have a play with doing this on as many patients as possible. It makes you much more sensitive to the complexity of delirium and much more wise about what is a hugely important condition. And we know it's an important condition from this beautiful paper which performed some years ago. And what happened in this randomized controlled trial was that 126 patients who were able to give consent, so this is the better part of the hip fracture population, were randomized to normal care or to the additional supervision by a geriatrician who was seeing them on a daily basis to try and optimize their care and try and prevent delirium. It's a lovely trial. It showed that the geriatrician, the comprehensive geriatric assessment, led to suggestions, a number of suggestions, an average of about 10 suggestions per patient of ways in which their care might be improved to try and reduce their risk of delirium. And 3/4 of those suggestions were something that could be achieved and was achieved. What's elegant about this paper, unlike most trials that describe the benefits of comprehensive geriatric assessment, is that this trial then tells you what was actually done. It's not a black box, mystical geriatrician intervention. They're very specific about what needed to be done for this group of patients, and that's hugely useful. And this paper therefore forms the basis of my teaching to junior doctors of what they should be doing on a post-take, on a daily ward round, when they're seeing their patients and assessing their patients throughout their time in hospital. So for your brain to work well, it needs to be having nice red, oxygenated, healthy blood perfusing it. So the expectation within this trial was that patients were not left unnecessarily anemic, they had enough blood pressure to perfuse their brain, and that their oxygens were well set. They had oxygen saturations that were adequate. So that's why we're looking at the OBS chart. That's why we're looking at patients' baseline bloods on a daily basis. They need to be properly hydrated, and they don't need to push into overhydration. The overhydration is pretty unusual in an orthopedic setting. Most patients seem to run rather dehydrated in the perioperative period. So making sure that people are adequately hydrated is hugely important. Managing pain is very, very complex, and there's a whole range of things we could talk about in terms of pain management. Everybody needs to be on enough paracetamol to reduce their dependence on other forms of analgesia. The role of nerve blocks is something that we could talk about at great length, but the nerve blocks have been very effective in dealing with the instant pain of an unfixed fracture or the post-operative pain of somebody who's just come back from hip fracture surgery. And again, a means of reducing their need for low-dose morphine or oxycodone. Using morphine in oral form, Oromorph, is now very easy in the UK. It's no longer a controlled drug. It's very easy to use. We don't tend to use any codeine at all in my hospital now, simply because the morphine is easily available. And the first thing a patient does with a codeine dose is has to metabolize it to morphine. So we cut out the middleman and just use Oromorph as our routine analgesia, except in people whose renal or cognitive impairment might argue for oxycodone as a less easy to administer because it takes 2 nurses, but less toxic, strong opiate. on every ward round, I'm looking at the drug chart, trying to get rid of drugs that might impair patients' cognition. And that's something that's a routine part of geriatrician care throughout patients' time in hospital. Trying to rationalise the drug chart. Bladder and bowel function is hugely important, making sure the patient's bowels do move. They're not going to move on the day of surgery. They're in pain. They can't consider moving onto a bedpan. They'd be horribly embarrassed to try and get on a bedpan to have their bowels open. They're on strong opiates and they're often dry. So I'm not expecting people to have their bowels open immediately. But if somebody's left needing to have their bowels open, particularly if they're quite shy about this issue, people can become very agitated simply about the fact that they want to have their bowels open, they need to have their bowels open, and they're too polite to mention it. So making sure that you understand patients' bowels and talk and manage that sympathetically is hugely important. Making sure the new parent is there to make sure that people aren't constipated for prolonged periods following surgery. Getting catheters out as quickly as possible, but being aware that acute urinary retention, particularly in men, can be a cause of post-operative difficulties is important. Making sure that people are able to eat properly, that they're in a position, they're supported and helped to eat. And one of the other YouTube videos I have is about our approach to nutritional support. It's a hugely important and impactful approach. Getting people out of bed on day one so that the objective of hip fracture surgery is not to fix the fracture. The objective of hip fracture surgery is that the patient can be sitting in a chair with lunch in front of them the day after their operation. So that's our target, and everybody needs to be able to work together to do that, to make that possible, if we're to avoid people becoming bewildered, lying in bed, looking at a ceiling, not understanding their environment. When you talk to medical juniors, if you talk to anybody doing the acute medical take, the expectation of when somebody comes into hospital who's confused is that it's a urine infection. That's the first thing everybody ever says to me. This is, of course, nonsense. Patients don't become acutely confused because they have a urine infection. Acutely confused patients may have a urine infection, but that isn't the reason they're confused. The reason they're confused, as we've already seen, we've got to 8 in the list of things that the Mark Antonio paper was assessing, is that all of those other things are not quite right as well. And that the urine infection may be the last straw that breaks the camel's back and pushes somebody who's in pain, on strong opiates, on the wrong medication, who's dehydrated, who can't get to the toilet, with all those other problems on a background of cognitive impairment. A urine infection may also be there, causing a degree of irritation or fever that may be the last straw that breaks the camel's back. But you don't get a camel up again by taking a straw off. You have to take the whole pile of difficult things off them. And the Mark Antonio trial showed that you needed to deal with several things if you were going to be effective in avoiding and treating delirium. So look for these medical things, and we're actually quite sensitive to these because medical school spends its whole time talking to us about these acute medical problems, but it's dealing with all the other issues that are important, including the environment in which the patient's looked after. So making sure that the ward is as homely as possible, that their communication aids, their glasses are available to them, that they're able to orientate themselves to the world around them, to try and protect them from the complexities that bewilder the strained brain in the post-operative period. And perhaps we can treat delirium. Often you're asked to see somebody and can you give them something because they become confused? And the answer is no, we're probably already giving them too much. We might need to give them some pain relief, and we might need to treat the other 9 things that I've just talked about. But drug treatment for a delirium is pretty ineffective and pretty inappropriate. There is little or no evidence that drug treatments work. However, in a subset of patients with delirium, you find that paranoia, psychotic symptomatology, can get in the way of your ability to work with them. They don't trust you, they won't take their food, they won't settle. And when those symptoms of paranoia and psychosis seem to be part of the delirium, then you may need to manage those. And in an RCT that we ran in our hospital, we used low-dose quetiapine, and that seemed to have a benefit in hastening the resolution of delirium in those patients who had psychotic, paranoid type, hallucinatory type symptoms, not as a sedative, but to try and take that one problem away, along with the other several things that needed to be treated for their delirium to settle. So drug treatment's not really very appropriate for most patients. And what the Marcantonio trial showed is that this sort of attention to everything reduced patients' risk of delirium. So even in this group of patients who were extremely well able to give consent when they first admitted to hospital, the rates of delirium in the control arm were about 50% of patients were identified as having delirium, and over a quarter were identified as having severe delirium. And those figures were essentially halved by attention to multifactorial assessment interventions, the comprehensive geriatric assessment work done by the geriatrician, the MDT. So this is a really powerful intervention that can impact on patients' time in hospital. The National Hip Fracture Database, the national audit of hip fracture in the UK, has been championing the importance of cognitive assessments and the understanding of dementia and delirium over 15 years now. And one of the things that we've been able to do is to learn about hip fracture patients and learn from them about the management of delirium and dementia in hospitals. Patients with hip fracture are just an ideal group from whom to learn. And some of the work that we've done is based on the fact that since the beginning, the NHFD has been implementing best practice tariff, an incentive-based structure for NHS England that meant that hospitals would lose money if they didn't ensure that all patients had a cognitive assessment when they were admitted to hospital. Initially, patients were having an abbreviated mental test score on admission and following surgery. Since 2017, they've been cognitively screened when they came into hospital, and we've been using the 4AT score as a routine in the post-op period, and that's been a very powerful tool. So the every patient's 4AT score is being recorded, and we've got very high rates of 4AT scores. So we've got hundreds of thousands of 4AT scores done within this population over the time since then. So that's routinely been recorded in the post-op period and built into post-op care bundles, which again is the topic of another of these YouTube videos. So everybody's seen on the post-op day to make sure their pain, their fluid management, their blood, nutrition, catheter, some of these aspects from the Marcantonio trial are dealt with, and then everybody's screened to identify those who do or don't have delirium. And what we've shown is that using that post-operative screening, we've found that about half of patients have a completely normal 4AT score, but another half don't, with perhaps a quarter of people having the score of 4 or above that's indicative of possible delirium. We've still got about 1 in 6 patients who are not having a 4AT score performed, so those figures will underestimate the overall rates of delirium. And within the UK population, these are the rates of patients being shown not to have delirium, having been assessed and having normal 4AT scores for all of the different hospitals in the UK. And you can see that over at the left-hand end, there are a number of hospitals in red where screening is less than adequate or care is less than adequate, and rates of demonstrated patients being demonstrated to be free of delirium are relatively poor. But across the majority of the country, we're seeing rates of delirium of about 30 to 40% of patients having abnormal 4AT scoring post-op. And that variation is still quite considerable between all of those hospitals where screening is routine. So there's a lot that can be done according to the Marcantonio model to try and improve function in those hospitals. We know that patients who have an abnormal mental test score, abbreviated mental test score out of 10 when they come into hospital, are the ones who tend to go on and have delirium. We've shown that previously. And in more recent work, Sam Hawley, using NHFD data, has been able to identify the risk factors that lead to patients being likely to have post-operative delirium. So patients who are the more frail individuals with the more dramatic The more challenging fracture types with more blood loss and more pain, the trochanteric types of fractures, patients who are malnourished, patients who fail to get a nerve block are all at increased risk. He's also shown that an abnormal 4AT score following surgery relates to the patient's outcome as well. And an elegant previous paper by Radcliffe Lisk and his team in Ashford showed that the same type of results could be seen even within a single hospital, so not dealing with big data in the way that the NHFD, so many of the NHFD papers are doing, but this is showing real effects on patients' mobilisation, length of stay, mortality and discharge destination to relate to their 4AT score in the post-operative period. So the NHFD will continue to champion the importance of delirium assessment as a fundamental part of hip fracture care. By measuring patients' 4AT on admission, we can identify patients who need to be protected against the risks of delirium in the perioperative period. By measuring it post-op, we can use post-operative delirium as a marker of the overall quality of the medical, nursing, surgical, anaesthetic care of the perioperative period. And we need to remember that the commonest complication of hip fracture surgery, of any general surgery, of any medical admission is delirium. And if we can challenge delirium, if we can avoid patients becoming delirious, we can continue to improve the quality and outcome of hip fracture care across the country.